Helen, thanks for your time today. We have now entered the HIV and TB funding crisis. Are we acting fast enough, and how should we navigate it?
Although we all anticipated that PEPFAR was reducing and the plan was that it would stop, we were thinking 1, 2, 3 years hence with a reduced amount of funding, which would have allowed adaptation and absorption into the system. What has really caused the crisis is the sudden stopping. For HIV and TB, it is critically important that people who are on treatment stay on treatment. If they don't stay on treatment, obviously what you get is, first of all, people getting very sick. Secondly, that you get a growth in the numbers of people who are infected with HIV or TB because you've just got more infectious people. And then you're going to get a huge burden on an already overstrained health service. So we do have a problem. You have to say, first and foremost, how do we keep patients in care? And how do we keep them on antiretrovirals? Secondly, how do we keep testing people? Because if we stop testing, we're going to get more new infections that we don't know and are not linked to care. And thirdly, related to this, how do we also keep our TB patients in care, and how do we test? So those are the sets of questions, and that's what we need to think about.
You head up the Wits Reproductive Health Institute that did receive a lot of PEPFAR funding. How have you seen the impact of that playing out?
We had significant funding from PEPFAR from both a USAID grant, which was stopped abruptly and suddenly, and that was in a rural area in the Free State. But it was also a grant that supported what we call key populations, and particularly services for sex workers, for men who have sex with men, and the transgender community. That was stopped very suddenly. A different part of that grant from USAID was also a national schools program where we had mobiles going out to schools and encouraging young people who were sexually active to test for HIV, to have pre-exposure prophylaxis, contraceptive services, counselling, mental health services as well. All of that stopped completely. At the moment, we're fortunate that we have another part of the PEPFAR grant, which is funded by CDC, which is a US institution, and that is continuing, but we don't know when that will stop. And that's supporting 2 large metropolitan areas.
Part of your program that you say is still running, that's funded through the Centers for Disease Control, did stop briefly for 2 weeks when it wasn't sure whether it was going to go ahead.
Yes, and in those 2 weeks, we were quite alarmed because in 2 metropolitan areas where we're working, we saw a loss of 8,000 people to follow up. These are people that would have normally come back for care, for antiretrovirals, for viral load testing in that 2-week period. 8,000 people didn't come. Now that could have been an artifact because the PEPFAR staff also supported the monitoring and evaluation of the program, so it could be that they just weren't captured in the program, but it could be that significant numbers did not return. And the fact that the National Health Laboratory Service has also seen a significant decrease in the number of viral loads that they're doing by about 1/5. That would suggest that we are definitely losing a proportion of people to follow up. And these are probably, pretty certainly, the most vulnerable people, the people that we were able to reach out for when we had the PEPFAR program, the people that we used outreach services, mobile clinics to identify, the people who we were able to send messages to, knock on doors, bringing them back in for treatment when they defaulted. That will be the group that is most vulnerable to being lost to follow-up.
What do you think are the ways to go ahead now that we don't have these PEPFAR workers who did the outreach services? How do we get around that?
What we will need to do is to, I would suggest, have an urgently convene a national think tank. There are some really superb people who've been working in the programs with the health department, closely and well with the health department, who are supported by the PEPFAR program, who could contribute their ideas and experiences together with the National Department of Health and the provinces to say, what have we learnt? What can we retain that isn't hugely expensive, but that we've learnt really does work? one of the suggestions prior to the PEPFAR stopping was that we should be giving longer durations of treatment instead of people coming back every month and waiting, that we use all the tricks that we've got to allow people to access treatment without having to go and sit and wait in clinics. But what we're hoping for now, and it's in the process of being registered, is that there are new drugs in the pipeline that we think are going to revolutionize HIV prevention. So we can't let our HIV prevention services go, or we won't have an outlet within which to offer these drugs. But then the immediate thing we have to do is to say, how do we secure prevention services?
In the next 6 months, what is it that you would recommend we do to keep people on treatment and to keep HIV prevention services intact?
We've got lots and lots of mobile clinics. They're there. They are sitting in garages being unused now because they were used for PEPFAR. If we can see that we have particularly vulnerable areas and vulnerable groups, then we should consider using those mobile clinics and employing staff in those areas to reach out to them. Allowing people to pick up their drugs without having to go into a clinic, sending messages on cell phones, phoning people who default, recognizing who are your defaulters and having some dedicated services for people that you know are going to default, but really recognizing what has worked and what is going to be most cost effective in terms of returns in the short term while we give ourselves the space to plan for the medium term. I think in the medium term we should actually say what technologies are available for us to have smarter health services. Because we're not doing it at the moment. And that would include digitalization of data, which is an ambition of the health services. Can we accelerate that? Because that will give us much more information, which will allow us to plan better for health services. So streamlining health services and actually using new technology to have more efficiencies is going to be critical, because it's not just more money in, it has to be a smarter way to use those funds.
So when it comes to digitizing our health system, especially with things like electronic patient record, it feels to me like we've been trying to do that forever and it's never coming together. So how do we get around that?
We cannot continue with the paper-based system that we had. Digitization will improve individual health management, it'll improve training for healthcare workers as well, it'll improve surveillance, it'll improve planning for responses and long-term planning as well. Where we get the money from, I mean, it is going to be a matter of looking at the budgets and saying, how do we fund this?
From this funding crisis, what have we learned about being so dependent on donors?
We can't have this dependency anymore. We must look at our own resources, and that's why I say innovative financing, other sources of financing, smarter health services, new technologies that reduce the loads on services and improve efficiencies. All of those in the medium term are the things that we need to look at, rather than saying, is there another funder out there? Because there isn't another funder out there that's going to replace PEPFAR.
Professor Helen Rees, thanks very much for your time today.
Pleasure. Thank you very much.